becoming bad day by day.
Yes, sir.
Yeah, I think you can go ahead, ma'am. Please start.
Right, right. So, good evening, everyone. So, in continuum of our decoding GI-HPB oncology webisode session. So, from today onwards, we are starting a new topic on esophageal and G-junction cancers. And like you all know, so we are covering all aspects, including anatomy, surgical aspects, the neoadjuvant, adjuvant, palliative setting, all aspects of the specific organ-based thing. So from today onwards, we'll be starting esophageal and G-junction cancers, and this whole webisode on esophageal cancers will be covered into 5 sessions. And to begin with, first session, we are starting on basics of esophageal and G-junction cancers, and we'll be covering the anatomy and radiology aspect, as well as the pre-operative workup and nutrition. So we have 3 eminent faculty members with us. So Dr. Jagannath Dixit, who is surgical oncologist in HCG Hospital, Bangalore, and Dr. Bharat Gupta, who is radiologist in TMC, Kolkata, and Dr. Prashant Penumadu, who is surgical oncologist from JIPMER. So very eminent faculties, and I hope you would like the session and contribute into the session also by putting up your questions in the chat box. So not taking much of your time, now I invite Sir Dr. Jagannath Dixit to begin his lecture, and he'll be covering on anatomy and staging of esophageal and G-junction cancer. So please start sharing your screen, and we'll be continuing now.
Is the slides visible now? Hello?
Yes, sir, they are visible. Yes, sir, they are visible.
Okay. Very good evening. I'm Dr. Jagannath Dixit. I'm a GI laparoscopic and robotic surgeon. Today, we will speak on the anatomy and the staging part of the esophageal cancer. So at the outset, I just want to give a little brief introduction about the anatomy of the esophagus. Is a narrow muscular tube extending from the pharynx to the stomach and descends in front of the vertebral column, goes through the superior and posterior mediastinum. So this mediastinum, the most of the structures of esophageal lymph nodes, nerves, and the vessels, and all that, they are placed, especially the vascular supply of the esophagus, are all come from the posterior mediastinum. So as we know that, the esophagus lower part starts from the lower part of the neck at the inferior border of the cricoid cartilage that correspond to C6 vertebra, extends to the cardiac orifice of the stomach, that is at the T11 vertebra. It gives a passage for chewed food and liquids, and during the third stage of deglutition. Dimensions of the esophagus: it is 25 centimeter tube, which almost 10 inches. Width is 2 centimeter. Lumen: it is flattened anterior posteriorly, and normally it kept closed. Because of the sphincters at the cricopharynx and the gastroesophageal junction, most of these sphincters are going to relax whenever during the act of deglutition. Otherwise, it's a collapsed structure. So that is a little bit. And then Here you can look at that the esophagus, and the important thing is that paraesophageal structures, the peritracheal lymph nodes and tracheobronchial lymph nodes. This is almost what we call subcarinal lymph nodes. These subcarinal lymph nodes are very constant lymph nodes located in and around the esophagus at the bifurcation of the carina. Then we have got posterior mediastinal lymph nodes, then the diaphragmatic lymph nodes. Then if you come lower down, and there is a lot of lymphatic plexus along the name vessels. They are basically the left gastric artery, splenic artery, and common hepatic artery. And that the origin of the this trunk called as celiac axis, which is a short trunk coming from directly from the aorta. So this is the lymphatic pathway of the stomach. So if you look at if you look at the with respect to the length of the esophagus, we 25 centimeters. So this starts from the cricopharynx, which is at 15 centimeters. That is the beginning of the esophagus. Then the 3 to 4 centimeters is called as a cervical esophagus. It's a very short segment. This is all located in the neck region, and then the every 6 centimeters is divided into the upper thoracic, mid thoracic, and the lower thoracic esophagus. So from 18 to 24 centimeters, we call it as the upper thoracic esophagus. And then from 24 to 32 centimeters, it's the mid thoracic esophagus. And 32 to 40 centimeters is uh, the lower thoracic, along with the abdominal part of the esophagus. Abdominal part of esophagus is roughly about 2 centimeters. So up to 38 centimeters in a normal height of the individual, it corresponds to about 36 or 37 or 38 centimeters gastroesophageal junction. Then we'll have another 2 centimeters, that is the abdominal part of the esophagus. Here you can look at that. This is very important for the surgeon. That is the type 1 and type 2 and type 3 lesions. So this is a Seward's classification of the esophageal G-Junction tumors. So the epicenter of the tumor location is very important. If the epicenter is located in the lower esophagus, it is called as a more of a Seward's type 1. And if the epicenter is located exactly matching at the junction of the food pipe and the stomach, it is called as type 2 lesions. And type 3 is basically more of cardiac thing, and no involvement on the esophageal side. So this classification is very important to understand whether the type of surgery to be done. So coming to the venous drainage, this venous supply is also very important. Just like arterial supply, this venous supply is segmental, and from the dense submucosal plexus, and venous blood drains into the SVC, and in the veins of proximal and distal esophagus drains into the azygous system, and the veins of mid esophagus and collateral drains into the left gastric vein. So this arterial supply has got a good arterial blood supply. Again, it is all segmental. That's why especially the mid esophagus lesions. If you resect it, you cannot anastomose, because you are going to lose the blood supply coming from the segmental branches. So that's why the minimum surgery, either it will be a total esophagectomy or distal esophagectomy with a partial, the proximal gastrectomy, like that, because this is a very hollow viscous muscular structure. You cannot pull and stitch it. So any loss of segmental blood supply amount to the vascularity of that portion of segment, and probably understanding this vascular anatomy is very important for the surgeon. See, few of the blood supply also come from the inferior thyroid artery. especially upper esophageal sphincter and the cervical esophagus gets a blood supply from the inferior thyroid artery. Again, it is coming from the thyrocervical trunk. Then there are multiple branches coming from either sides of the aortic branches. These are the terminal branches, and they supply the upper, mid, and lower thoracic esophagus. Aorta is a very adjacent structure close to the esophagus, and the left gastric artery and branches of the left phrenic artery, they supply the lower esophageal sphincter and most distal segment of the esophagus. So it's a very, very beautiful arterial anatomy coming from in all direction, one from the neck side and maximum from the thoracic side, and also and almost the entire lower esophagus and including the stomach is supplied by the left gastric artery and also the left phrenic artery. So lymphatics, it's very, very important. The proximal 1/3 drains into the deep cervical nodes and subsequently into the thoracic duct. See, any lesions, esophageal cancers, the upper esophageal, that is a cervical esophagus, or the upper thoracic esophagus, all that, the lymphatic drainage is more common to the either supraclavicular nodes or the right or the left side, or into the even up to the behind the sternomastoid. So mid esophagus, mid 1/3 esophagus drains into the superior and posterior mediastinal nodes. This is a very, very constant, but any enlarged nodes cannot be metastatic always, but it has to be correlated with the imaging that I will just elaborate on that later. And distal 1/3 of the esophagus, the gastric and the celiac lymph nodes. So that is the good amount of rich lymphatic drainage. Just like arterial and venous drainage, there is a good amount of lymphatic drainage in all the directions. So surgical importance, submucosal lymphatics explain why a tumors extends a long distance before the obstructing the lumen. May also explain the high recurrence rates and bidirectional lymph flow. They explain the retrograde tumor seedling and if the flow is blocked. So this is very important. That's why the concept of lymph node lymphadenectomy came into thing. But lymphadenectomy in a defined anatomical area, we call it as a lymphadenectomy. Here you can look at single stage lymphadenectomy in the first picture, and this is the single stage lymphadenectomy where you remove the lymph nodes below the bifurcation of the carina up to the G-junction and including the celiac and the left gastric. Whereas two-stage lymphadenectomy, it includes the lymphatic dissection of the in the first one, along with added above the carina and almost below the level of esophagus vein. So this is the two-stage lymphadenectomy. This is a very, very commonly done two-stage lymphadenectomy for all the mid esophagus and the lower esophagus. Most of the time, upper esophageal lesions, we don't take it up for the upfront surgery or definitive surgery because it has got a rich amount of lymphatic drainage which can go into the supraclavicular and other deep cervical group of lymph nodes. And but the mid and the lower esophagus, we do commonly two-stage lymphadenectomy. Then came into what is called as three-stage lymphadenectomy. This is a very morbid procedure and it can carry a lot of lymphoria, and patient also might go into the sometime uh, lymphoria with a thoracic duct injury, or with a chyle leak, or even a patient might need some ventilatory assistance because of the too much of lymphoria in the entire mediastinum and also into the neck region.
Sir, sorry to interrupt you. Can you make it a full screen so that it is more clearly visible?
Okay, sorry.
Thank you.
I will do that.
No worries, sir. Okay.
Okay, now is it full screen now?
Yes, sir. Yes, sir.
Ah,
Please go ahead. Yeah.
yeah, okay. So here, if you look at that, the celiac trunk, I think this is a very important thing. Not only the esophageal arterial anatomy is similarly the gastric arterial anatomy is very important for the surgeon. So the left gastric artery, takes off from the celiac trunk. It has got a slightly a bend angulated course. It runs along the lesser curvature of the stomach, and before reaching into the stomach proper, it divides and gives a entire a blood supply along the distal and proximal lesser curvature of the stomach. The splenic artery has got a very tortuous course, and it has got a along the superior border of the pancreas. This almost reaches, and in a D2 lymphadenectomy, that is the clearance along the left gastric, splenic, and the common hepatic named vessel, and even we have got a extended D2 resection. So all this, the vascular anatomy is very, very important. And here lower down comes what is called as a right gastroepiploic artery. The entire blood supply of the stomach along the greater curvature depends on the right gastroepiploic artery. And there are few branches called as short gastric arteries. They are coming from the left gastroepiploic artery. So if you are preparing the gastric conduit and doing the anastomosis in the gastric pull-up, the entire preservation of the right gastroepiploic artery is very important. Suppose if you want to do the supercharge of the proximal stomach, also retaining the left gastric artery branches, and also you know if you want to put some other jejunal graft into the stomach for a total laryngopharyngoesophagectomy, this arterial anatomy is very, very important. So here, if you can look at that this esophagus gets both sympathetic and parasympathetic plexus nerve supply, and here and there we are having a ganglion. This is a very important station, and the parasympathetic supply comes along the recurrent laryngeal nerve, and sympathetic chain also supplies the entire esophageal musculature, and this is a very, very beautiful anatomy. And some branches of the cardiac branches also come from the parasympathetic chain. But whenever we transect the vagus nerve, but some of these cardiac branches to the will be preserved, and there will not be any morbidity with doing a transection of the vagal trunk. The lymphatic drainage is very, very important, and we have got a long course of the thoracic duct starting from the along the the cisterna chyli, and comes all along the diaphragm, through the diaphragm. In the diaphragm we are having a three opening that it's called voice of America, where the vena cava comes the anterior, then the esophagus comes the middle, and the aorta comes the center one. So this is along with this trunk on the esophageal along the aorta, this thoracic duct runs along, and in the paravertebral region, and almost takes in the lower half and mid half, it is on the right side of the esophagus. Then at the level of angle of Lewis, and it makes a turn and runs along the left side of the esophagus, then comes at the junction of the subclavian and interjugular vein, and it opens into the venous system. So this is very important. Suppose sometime the common injuries or the ligation happens in the lower half of the esophagus during the esophageal mobilization, or when we are doing a radical lymphadenectomy. Electively, we clip this thoracic duct and then go ahead with the surgery. But sometime if the lymphatic lymphadenectomy is too extensive, and prophylactic ligation is important, Otherwise, inadvertent injury of the thoracic duct on the table, if you're able to identify and clip it, it is excellent. Otherwise, it is one of the morbidity and can lead to mortality also. But thoracic duct, injuries management is totally different thing, and there are different ways of to address that. So coming to the staging of the esophageal cancer, see, esophagus is just like a gastric, the submucosa of the esophagus is a very very important thing, because that is the toughest layer of the esophagus, and here we see that whenever there is a mucosal and submucosal involvement, there can be almost 50 to 60% of the lymphatic chains opens up, and there can be a lymph node involvement. So here, just like any other visceral staging, esophagus has got the similar TIIS, that is called in situ cancer. T1 is the involvement of the there is a what is called T1a and T1b, and it is the the pure first layer of the mucosa, and then submuscularis muscularis mucosal involvement become T1b, and T2 is the submucosal involvement, and then the T3 is the muscularis propria involvement, and the T4 is the adjacent organ involvement outside the adventitia of the esophagus. Similarly, we have got what is called as N0, that is the no lymph node involvement. Normal hilum architecture is preserved, and N1 is 1 to 2 lymph nodes, and N2 is 3 to 6 lymph nodes. N3 is more than 7 lymph nodes involvement. So this TNM staging, especially T status and the N status in the pre-operative staging, we have to believe on the endoscopic ultrasound. This is one of the advanced imaging technology where we will be able to look at the layer by layer involvement of the esophagus. But the problem is, if there is a constricting and large ulcerated lesions where the scope is not going and beyond distally, and probably those are the subset of cases where the T and N status we can, but T status sometime, if it is not going beyond the tumor, and the scope is sitting proximal to the lesion, then probably accurate thickness of the lesions very difficult to make out. But most of the time we believe on the pathological staging rather than the clinical staging. But clinical staging of the esophageal cancer is very important to plan the treatment. Whenever there is a obvious nodal involvement, it will be stage to upstage to 3. I will just come to that. So then comes another subset of entity is a Barrett esophagus. Normally, this lower end of esophagus is lined by the squamous epithelium. If the lining epithelium changes from the squamous to columnar epithelium, then we call it as a Barrett's esophagus. Is one of the pre-malignant lesion. So these lesions can be reversible in few of the patients, but if it goes unnoticed, and this will definitely develop into a adenocarcinoma gastroesophageal junction. So that is again very important entity in the understanding the development of the cancer. I think we have dealt about this. See, this esophageal thing, always we have to look at in different ways. One from the anterior approach and another from the posterior approach. The figure, the view B shows the posterior approach, where the behind the vertebral column, then there is a hollow viscus, that is the esophagus. And but if you look at from anterior through the sternum, if you go, then you will get the major vessels first, and then you will get the trachea and the major vessels, then comes the esophagus. So esophagus is a very very deep structure, structure if you look at from anterior to the posterior. But if you look at from posterior to anterior, esophagus is a quite accessible for doing surgery from the posterior to anterior approach. And the earlier, before the imaging like CT and PET CTs and all that, we always try to take a X-ray of the thoracolum, I mean cervical and the thoracic vertebra, and try to look at the the lesion with a barium, and look at the location of the lesion and the with the height of the vertebral body, and also with respect to the vertebral bodies like number or the cervical vertebral bodies. So like each vertebral body, this is the distance, and like if it's involving 1.5 vertebra or 2 vertebra and all that. But later, because of the good imaging with the CT, coronal and axial section, definitely with the oral contrast and the IV contrast, we will be able to locate these lesions, the cervical esophagus, upper thoracic and all that. With respect to vertebral bodies, we can look at the where the lesion is located. And lower down, you can see also the gastroesophageal junction, that is at the level of diaphragm, and above and below, and you can exactly locate how far is the G-junction involved. But always this has to be correlated with endoscopic finding before we plan. So here it indicates that the posterior approach of the for the esophagectomy, including the G-junction tumor, it is quite easier to do. But any lesions which are located higher up above the above the azygos level, there is a very cramped space with the thoracic inlet and all the the crowding of the ribs and all the major structures coming there, and especially the upper thoracic esophagus, where there is a thin layer of membranous trachea in contact with the esophagus. It's very, very difficult to dissect even with robotic or the VATS transthoracic surgery. But the rest of the mid esophagus, and to some extent at the level or above the level of carina, we can definitely do a good mobilization, do the good lymphadenectomy of the esophagus. And here is you can look at the the esophageal specimen. It is not only the removal of the esophagus, along with that lymphoareolar tissues and the fatty tissues, and also the subcarinal lymph nodes, so posterior mediastinal lymph nodes, and also you're taking a cuff of the G junction along the less proximal lesser curvature is very important. So this anatomy is very important before we plan for any treatment. So coming to the last slide, this is regarding the staging. I think staging already partly I have covered. The high grade dysplasia, that is especially the if the basement membrane is not invaded, we call it as in situ, and also with the degree of dysplasia, we can plan the definitive treatment. And T1A, T1B, T1B, I think I have already explained all this thing. And there are grading of the histological grading. Let us not go into that depth, because histologic grading with a small biopsy might vary with histological grading with a definitive surgery. But the squamous cell carcinomas are more common in the entire esophagus. Only the G-junction tumors can be either squamous or can be adeno also. So this is a group staging. When you club all that, we have got a CTNM, that is a clinical staging. T1, T2. So any nodal involvement will upstage things to the N0 or N1 will become stage 1 and 2. And stage 3, it is always the T3 lesions with nodal involvement. And stage 4 is adjacent structure involvement, including pericardium, trachea, and then the adventitia of the aorta. Arc of contact is very important. And so the stage 4B is the distant metastasis to the pleura, lung, and supraclavicular nodes, and liver and other things. So we have got pathological staging, and post neoadjuvant we have got VTNM. So that is following neoadjuvant chemotherapy. We need to restage with the imaging and look at how is the response to the chemoradiotherapy. This chemoradiotherapy is a common practice for all mid and lower esophageal. But if it comes to adenocarcinoma G-Junction, most of the time we practice what is called magic trial with slot chemotherapy followed by the imaging. So I finished my talk, I think. If any questions, I can take it.
Yeah. Thank you so much, sir, for very crisp and elaborate discussion. So Dr. Nupur has put a question in the chat box, and I would request you to take that question. So she asked, is celiac node involvement considered regional node even for the cervical esophagus? And similarly, supraclav, is it a regional node for lower esophageal tumor? And after this question, one question I also do have it, if somebody has a distal esophagus tumor and there is a supraclav node, so do you address supraclav node surgically, or do you not address it surgically and deal it with the radiation and other aspects?
Yeah, it's a very important question. See, there are what we call, there is a regional node and juxta-regional group of lymph nodes and metastatic node. Any disease located in the lower esophagus with a supraclavicular node, it becomes a M1 disease. But if the cervical esophagus, upper esophagus, then the supraclavicular nodes becomes a regional group of lymph nodes. But for upper esophagus, if celiac nodes becomes a metastatic. So always, the station by station, if you look at that, if it is crossing more than one station, we don't call it as a regional group of lymph nodes. But these patients have to be subjected for systemic treatment. And suppose if you are planning for a 3-stage lymphadenectomy, then it's okay. But a 3-stage lymphadenectomy, it has got its own consequences post-surgery. I think we don't consider it as a regional nodes. Celiac nodes, they are called as a metastatic group of lymph nodes.
Right, sir. Right. Thank you so much, sir. And since there are no more questions in the chat box, so we will move ahead towards the next talk. And I would like to invite Dr. Bharat Gupta, who is a radiologist in TMC Kolkata, and he'll be discussing about radiological evaluation of the esophageal and G-junction cancers. So Dr. Bharat, please, you can start your talk.
Am I audible?
Yeah.
Yeah.
Okay. Yes, you are audible, sir.
Okay, I will start sharing my screen.
Yes, please.
Okay. So my screen is visible, right?
No, not yet. Yeah, it is now visible, but we can't see your slides yet. Yes, the slides are also visible, and you can make it full screen and then continue. Yes, please.
Okay. Good evening, everybody. Basically, I'm working as an interventional radiologist at Tata Medical Center, Kolkata. So the topic for today, I will discuss is role of imaging in management of esophageal cancers. We will try to solve a lot of queries in this session. So what is the modality of choice, initial modality of choice? What should be done post neoadjuvant therapy? So we'll try to solve all the queries. We will discussing about the division and anatomy of the esophagus, which is very relevant in context to management. Second, we will discuss regarding the staging and the role of imaging in staging and what all modalities are generally used to stage esophageal tumors. Then we will discuss the role of imaging post neoadjuvant therapy. And in the last, if we get time, we will discuss regarding post-surgical imaging and some complications. So it is very well highlighted by sir, the divisions of esophagus. It is already discussed very nicely. So up to 15 centimeter from the incisors, that is measured endoscopically. It is it's the upper esophagus sphincter. So from 15 to 20 centimeter is the cervical esophagus, 20 to 25 is the upper thoracic, 25 to 30 is the middle thoracic, and from 30 to 40 centimeter is the lower thoracic esophagus. So what will be the imaging landmarks for this division? So 15 centimeter from the incisors is the cricopharyngeus. So in between the cricopharyngeus and the sternal notch will be the cervical esophagus. In between the sternal notch and the azygous vein will be the upper thoracic. In between the azygous vein and the inferior pulmonary vein will be the, inferior pulmonary vein will be the middle thoracic esophagus. And in between the inferior pulmonary vein and the G-junction, that is 30 to 40 centimeter, will be the lower thoracic esophagus. So now coming to the surgeons are generally tuned to see the axial CT section. So I will show you the axial contrast enhanced CT scan and relevantly divide the esophagus. So this is the level of the cricoid cartilage, which is marked in red. So as we go down, we can, from the cricoid cartilage, the cervical esophagus starts. So as we go down, we can see the trachea anteriorly, the cervical esophagus posteriorly. So now when we go down, then anteriorly we see the manubrium. So this marks the end of the cervical esophagus and the start of the upper thoracic esophagus. So anteriorly we can see the trachea, posteriorly the cervical esophagus, and laterally we can see the great vessels. So now as we go down again in the axial sections, we can see the arch of aorta laterally, trachea anteriorly, the esophagus, distended esophagus posteriorly, and the vertebral bodies. So at the level of carina, this marks the end of the upper thoracic esophagus, carina or the azygous vein. So from sternal notch to the carinal angle is the upper thoracic esophagus. So as we go down from the carinal angle, we can see the distended esophagus closely. It is related to the left main bronchus and the descending aorta. So any tumors located in the middle thoracic esophagus, they generally tend to invade the trachea and the descending aorta, because the esophagus is, there is no serosa in the esophagus and they easily spread to the adjacent structures. So as we go down from the carinal angle to the left inferior pulmonary vein, we can see the left inferior pulmonary vein joining the left atrium. It is the middle thoracic esophagus. And from left inferior pulmonary vein, as we go down up to the G-junction, we can see the lower thoracic esophagus. So definitely we can see a growth here in the lower thoracic esophagus, causing a distension of the proximal esophagus. So what will be the landmark for the gastroesophageal junction? So G-junction basically,
Dr. Bharat, we are not able to hear you. There is some voice disturbance.
Am I audible now?
Yeah, you are audible now. Yes, please.
Okay. So where the diaphragmatic crust join medially, it is the generally taken as the G-junction. So G-junction on cross-sectional imaging is very difficult to identify. So generally it is confounded with endoscopy. So now coming to the G-junction tumors. So G-junction tumors, so any tumor with epicenter within the 2 centimeter of the cardia of stomach will be considered as G-junction tumors, and any tumor with epicenter more than 2 centimeter from the G-junction, even if it is involving the G-junction, will be considered as stomach cancer. So according to AJCC 8, CVAT 1 and CVAT 2 will be treated as esophageal cancers, and CVAT 3 will be treated as gastric cancer. So here on this image, we can see there is a tumor in the G-junction, which is just extending into the cardia, but the epicenter of the tumor is still in the G-junction. So we will classify it as a G-junction tumor and treat it accordingly. So down as we go in this CT image, we can see there is tumor involving the G-junction. And as we go down, we can see that the bulk of tumor, it is more involving the cardia of the stomach. So epicenter is more than 2 centimeters away from the cardia. So it is generally taken as a gastric cancer. So why it is important? So division of esophagus is important because the management changes accordingly. The cervical esophagus tumors are generally treated with definitive CT-RT. In our institute, we follow the SCOPE protocol. So upper, middle, and thoracic esophageal tumors are treated with NACT-RT followed by surgery depending upon the stage. So in our institute, we follow this cross protocol followed by surgery. So this is now the standard of care, giving cisplatin-based chemotherapy followed by surgery. So G-junction tumors are generally treated as stomach or esophageal tumors depending upon the histology. So if it comes as a squamous cell tumor, it is treated with cross followed by surgery. If it comes as an adenocarcinoma, it is treated as FLOT followed by surgery. So this staging is already discussed in detail by Sir. So I will just highlight a few important points. So important is to identify the T1b stage and the T4 stage. So T1b is involvement of the submucosa and T4 is extension beyond the adventitia of the esophagus. So T4A is involvement of the pleura, the pericardium and the peritoneum, and T4B is involvement of the aorta, the tracheobronchial tree or the vertebral body. So actually the management completely changes with the involvement of the T1B, that is involvement of the submucosa. So there will be increased chance of nodal spread. So various papers have shown that 30 to 40% increase of nodal spread is there if there is the stage of the tumor is T1b. So N stage is already discussed by Sir, N1, N2 and N3 depending upon the number of nodes involved, and M is M0 and M1 depending upon the distant metastasis or non-regional lymph nodes. So distant metastasis can occur to lung, liver, most commonly into the liver. So now we will discuss the role of imaging in staging of esophageal cancers. So basically to detect esophageal cancer, there is very less role of imaging. So imaging mainly helps in staging and to guide further management. So, but still accurate clinical staging is still a problem with the current imaging modalities. So we have various modalities like CT, PET-CT and US. So all these modalities actually complement each other in accurate pre-treatment clinical staging. But endoscopic ultrasound has still a very limited role in staging of esophageal tumors. So coming to T staging, so EUS mainly helps in differentiating T1A and T1B lesions with sensitivity and specificity of 72 to 85%. So our main aim in endoscopic US is to differentiate between T1A and T1B. So this paper highlights the accuracy of endoscopic ultrasound in differentiating T1, T2 and T3 tumors. So this paper states that endoscopy still has very limited role. It falsely stages gives the T staging. So this is a case in which there was a growth in the cecum for which PET-CT was done, and there was an incidental thickening in the lower thoracic esophagus, which was PET-avid. So patient had actually no complaints of dysphagia, nothing, but there was some thickening, and so endoscopy was done. So in endoscopy, it was reported as endoscopy was done and biopsy was taken. It was reported as adenocarcinoma. And subsequently, it was referred for EUS. EUS, it was staged as T1B with a very small node. The point I here want to highlight is that cross-sectional imaging it is very difficult to stage give the T staging on cross-sectional imaging. So role of CT and PET-CT. So generally, esophageal tumors are seen as diffuse wall thickening on CT scan or PET scan, which is non-specific. So it can be seen in inflammatory conditions as well. So CT and PET-CT is actually unable to differentiate between T1, T2 or T3 tumors. So now here comes the role of endoscopy, but endoscopy, hello? Yes, here comes the role of endoscopy. So, but endoscopy still, a lot of confusion is there if it helps in management or not. So CT actually helps in staging give the T4 staging. So it helps to possibly see the invasion of the adjacent structures. So CT helps to detect the aortic involvement or the tracheobronchial invasion with 100% sensitivity and specificity. So trachea and bronchus invasion on CT is, if it is seen on CT, is actually confirmed on bronchoscopy. So it becomes a relative contraindication for radiotherapy. So these patients with T4 disease and there is frank mucosal invasion of trachea on bronchoscopy, so they generally are referred for palliative chemotherapy. So this is a tumor which is located in the lower thoracic esophagus. So there is extension into the periesophageal fat, but the fat planes with the atrium and the descending aorta are well maintained. So it was staged as CT3 on CT scan. So again, it is we can see there is a tumor in the upper thoracic esophagus, which is indenting into the posterior wall of the trachea. So for this, again, bronchoscopy was done to confirm the mucosal invasion. So there was actually no invasion of the mucosa. It was staged as T4A. So T4B, this is another scan which is showing there is a frank invasion in the left main bronchus, and there is more than 90% 90 degree encasement of the descending aorta. So it is staged as T4B. So nodal staging is very important to guide the management and to prognosticate the disease. So in esophagus, basically it is bidirectional nodal spread with the skip metastasis, as it is already discussed. So from lower thoracic esophagus, the lymph node, we can see positive cervical lymph nodes or supraclavicular lymph nodes, and vice versa. From cervical esophagus, we can see nodal spread to the celiac lymph nodes. So for every location of the tumor extending from the cervical to the lower thoracic esophagus or G-junction, any node from neck to the celiac region will be taken as a regional lymph node. So according to the AJCC, lower cervical paratracheal lymph nodes to the celiac lymph nodes will be taken as regional nodes. So N1 and N3 staging is based on the number of regional lymph nodes involved. So non-regional lymph nodes are considered metastatic, will be taken as M1, and directly they will be referred for PAL chemo. So supraclavicular, pulmonary hilar, and retroperitoneal lymph nodes are taken as metastatic. So these will be taken as non-regional lymph nodes. So this is a case where we can see a FDG avid growth in the lower thoracic esophagus. So multiple, this is the celiac artery, and we can see multiple FDG avid lymph nodes along the celiac axis and along the left gastric artery. So the number of nodes were more than 7. So clinically it was CN3 disease. So there is still a controversy there, which imaging modality is best for preclinical staging. So PET-CT, it is generally considered superior to CT for detection of lymph node metastasis. So nodal classification actually allows stratification for overall survival after surgery, and it's an independent predictor of survival in esophageal cancers. So what NCCN recommends that PET-CT and CT can be done, both can be done for preclinical staging, pre-surgical staging, but PET-CT is generally preferred. So what is done if there is a PET positive pulmonary hilar lymph node, or when there is a PET positive SCF retroperitoneal lymph node? So generally, if there is a PET positive SCF or a retroperitoneal lymph node, it goes for image guided sampling to see whether it is a nodal involvement is there or not. So if there are positive retroperitoneal or SCF lymph nodes, it is taken as metastatic disease. So PET positive pulmonary lymph nodes, pulmonary hilar lymph nodes is still a problem. It is very difficult to sample, and in a lot of cases with the latent tuberculosis and previously treated tuberculosis, we see a lot of pulmonary hilar lymph nodes. So this is a paper which highlights the importance of PET-CT in detecting hilar lymph nodes. So if hilar lymph nodes are positive, PET positive, their patient can go for upfront surgery. So we have already discussed PET-CT versus CT for initial staging. So PET-CT is preferred. PET-CT has a higher sensitivity and specificity for nodal staging and distant metastasis. NCCN recommends any modality can be used, but PET-CT is preferred. So what is the role of imaging? Role of imaging is to detect non-regional lymph nodes and distant metastasis. So what is the role of endoscopic ultrasound? So this is again very controversial, because in Indian scenario, we generally see advanced disease when the patient comes with dysphagia. We rarely see early esophageal cancer like the Japanese people. So it is mainly indicated in incidentally detected early esophageal cancer for local staging, for lymph node detection in early cancer, followed by sampling. So if in PET-CT retrospectively we see that there is no nodes or the disease is early, so endoscopic ultrasound can be done to rule out, to see the T staging and to sample the lymph nodes. So what is the management which is actually done depending upon the staging? So T1a, they generally go for endoscopic mucosal resection. T1b, node negative, they go for upfront surgery. T1b node positive, and T2 to T4a with any N or M0, they go for NACT-RT followed by surgery. So basically endoscopic ultrasound helps to differentiate between T1a and T1b. So we can, T1a can directly go for endoscopic mucosal resection, and T1b with node negative can go for upfront surgery. So role of imaging in neoadjuvant therapy, post-neoadjuvant therapy. So post-neoadjuvant therapy, major role of imaging is to assess disease response and to filter out non-responders. So this has a significance, because if a patient progresses or there is no response after neoadjuvant therapy, they are generally not taken up for surgery. So if there is a significant imaging response post-neoadjuvant therapy, it suggests better overall survival. So generally in our series, we have seen that approximately 15% patient after neoadjuvant therapy have complete pathological response. So on final post-op staging, there is actually no tumor post NACT-RT. This actually forms the basis of SANO trial, which is active surveillance post NACT-RT. Endoscopic ultrasound has no role in post neoadjuvant treatment. So basically it is the cross-sectional imaging CT or PET-CT which is done. So PET-CT or CT, it is done after 2 weeks of completing the therapy to rule out the false positives. So after radiation, there can be some inflammatory changes in the esophagus, which can show FDG avidity. So it is generally done after 2 weeks. But NCCN, they don't recommend PET-CT or CT, which is better, but still it is an institutional protocol. We generally do CT after neoadjuvant therapy. The reason is because of the cost constraints, and it causes, it is really cheap. So this is one case which I want to show is there is a growth in the lower, in the middle thoracic esophagus. FDG avid lesion is seen in the middle thoracic esophagus. So post cross, there was complete response and no lesion was seen in the follow-up CT. Patient was taken up for surgery in 2015. So still the patient is surviving. The point what I want to highlight is that if there is good response post NACT-RT, they generally do well. So multiple papers are there which suggest this, that if post NACT-RT there is good response, they generally have a very good prognosis. So this is another case in which there is FDG-avid growth in the lower thoracic esophagus. So post cross, there is some response with decrease in the thickening, esophageal thickening, and we can see there is some lumen patency. But the important thing was on chest CT, there was a new nodule in the left upper lobe. So, which was not there previously. So actually it was very confusing what to do. So it was either a metastatic nodule, or it was a second primary. So generally post cross, the disease doesn't progress, but still there was a new nodule, so we biopsied it. So it came out to be a granulomatous inflammation. So point what I want to highlight is post cross. So there might be some latent infection or tuberculosis which generally flare up. So if there is a response in the primary disease and still we are seeing some new nodules and new nodes in the chest CT or PET CT, so it should be reported very judiciously and very cautiously. This thing we have seen in multiple cases, like post cross, new pulmonary hilar lymph nodes are coming up, or new small lung nodules are they come up and they are taken, ultimately they are taken up for sampling to rule out disease progression. So this is another case in which there is a tumor involving the G-junction. So post chemotherapy, there was actually no response in the tumor. So it was almost similar. So in patient was operated and Ivor-Lewis esophagectomy was done. And in within 6 months, patient recurred and presented with obstructive jaundice. We can see biliary dilatation, lot of disease in the retroperitoneum, and a lot of nodes along the celiac axis. The point I want to highlight is generally if the disease is not responding post NACT-RT, they generally don't, the patients generally don't do well. So they carry a poor prognosis. So our role in imaging is to basically look for non-responders. So now coming to the complications. So anastomotic leak is the most common complication which is seen. It is seen in 10 to 44% of the cases. It has 40% post-op mortality. So pulmonary complications like pleural effusion, pneumothorax are very common with transthoracic approaches. So chylothorax is also a very difficult complication to manage. It is rarely seen, but if it is there, then it is very tough to manage chylothorax. We have to like re-intervene or do some image-guided interventions. So fistula formation, anastomotic stricture, it can be either benign or malignant. Benign stricture generally go for endoscopic dilatation, and malignant strictures, they actually are referred for palliative chemotherapy or herniation. So these are the major complications which are seen post esophagectomy. So this is a case in which there was a growth in the lower thoracic esophagus extending into the G-junction. So post cross, we can see there is reduction in the size of the tumor. So patient underwent Ivor-Lewis esophagectomy and there was a leak in the mediastinum. So we can see there is contrast, oral contrast was given and it was leaking into the mediastinum. Patient deteriorated 7th day post surgery and this scan was done. So we had put a CT guided drain into the collection and patient was discharged with a drain. So 2 months after putting this drain, we gave oral contrast. We did a repeat scan, gave oral contrast, documented that there is no leak, and after that the pigtail was removed. So this is another case in which there is a growth in the G-junction. So 6 months after the surgery, patient presented with absolute dysphagia. So in this case, Ivor-Lewis esophagectomy was done. So along the anastomotic side, we can see there is some thickening or growth, and which was FDG avid, and endoscopy was done in this case, and it was proved to be a adenocarcinoma with the metastasis involving the ribs. This is another case in which there is a FDG avid growth in the lower thoracic esophagus involving the G-Junction. It is involving the G-Junction. So in this case, VATS TTE was done. And after the VATS TTE, patient went into sepsis, admitted in ICU. We did a scan. There was a leak into the mediastinum. There was a collection which was communicating with the esophageal conduit. We inserted a pigtail into that. So after insertion of the pigtail, the patient improved, but still again the pigtail was not draining. Patient again deteriorated. We inserted a larger Melicot catheter. So patient was discharged on this catheter, and after few weeks, this cavity actually reduced in size. But 6 months after the surgery, patient came to the emergency with sudden hematemesis. So we did a contrast scan. There was this cavity was persisting, and there was some contrast extravasation along the esophageal wall. So patient was taken up for. So this was basically a esophageal pleural fistula, which was communicating and which was causing this problem. So we did a pulmonary angiogram to see for the bleeding side, but pulmonary angiogram, there was no bleeding was seen, nothing was seen, no extravasation of contrast was seen. So ultimately what we did was we injected under CT guidance, we injected glue into along the wall of the cavity. So this is the post-procedure X-ray. We can see there is glue into the cavity of this lesion. So take home point, what is important is location of the primary tumor. It is very important to locate. It helps in the management. So role of imaging is to define the local extent and to rule out distant metastasis, and to see for basically we have to see for non-regional lymph nodes and distant mets involving the lungs or the livers or the retroperitoneum. So for initial imaging, PET-CT is the investigation of choice, as already explained. And imaging is not to detect esophageal tumor, it is just to stage the esophageal tumors. EUS has a very limited indications, and it is basically useful to detect early tumors and differentiate between T1a and T1b lesions. Accurate radiological pre-op clinical staging is still very difficult, and very limited thing is there, because it is very difficult to accurately stage, and it is clinically not required also to accurately stage esophageal tumors before surgery. So image guided interventions are mainstay in the management of esophageal tumors. Thank you.
Yeah, thank you, Dr. Bharat, for a very informative lecture. So we will take a few questions which have been posted. So though some of them you have already answered, but for the sake of audience, we'll discuss it again. So the first question is, can we comment upon T1b on CT?
No,
Okay.
No, it is not at all possible to comment upon T1b on CT scan.
All right. So
Basically,
EUS is the modality.
EUS is the modality to differentiate between T1a and T1b, because T1b, there is submucosal involvement. It will actually change the management.
Right. So the next question is, which is modality of choice for the plan of treatment? Is it CT or PET-CT?
See, there are multiple papers which highlight importance of both. So PET-CT, NCCN states both CT or PET-CT can be used. But to detect nodal metastasis and to see skip lesions, there are papers which say PET-CT should be the initial modality of choice, and it is generally followed everywhere. So in our institute also we do PET CT before for preclinical, like pre-surgical staging.
Yeah. So if I sum up, once you are planning a radical intent treatment for esophagus and you are planning to rule out everything, so PET CT should be done.
Yeah, for radical treatment,
in the ideal condition.
PET CT should be done. For NACT-RT post neoadjuvant, actually PET CT is preferred. Many, if you are doing PET CT before, we should do PET CT. But in our hospital, because of costs and time constraints, we are just doing CT because it actually doesn't matter.
Right. Yeah. So good you highlighted that point, that for response assessment also, ideally, I mean, it's better if we get a PET CT done at the baseline and then follow it up.
Yeah, if
before the radical intent.
Then follow up with PET CT is always better, but it will not change your management.
Correct. Right. So the next question is, what is the size criteria for lymph nodal mets? Because sampling may not be possible or may not be easy at every place and at every time. So can we, so if I make it correct, so can we rely also on imaging for the lymph nodal metastasis labeling if sampling is not possible? So how confident are we on labeling a lymph nodal involvement?
See, on CT, if more than 1 centimeter, it has high sensitivity and specificity for detecting metastasis. And if PET CT, if it is avid and more than 1 centimeter, so it has still higher. But actually, what is recommended is, if you are seeing any FDG avid node that is non-regional, so we should sample it and prove it, because it completely changes the management from radical to palliative.
Right.
Hello.
Right. I do agree. And Dr. Manish, please. Yes.
Yes. So Dr. Bharat, very good lecture for us. And just I want to know, means for the benefit of students, what are the other imaging criteria for saying that it is a metastatic lymph node? Particularly when you say that pulmonary hilar lymph nodes is a difficult area, means pulmonary hilar lymph nodes can flare up after neoadjuvant CT-RT.
Yes.
So how do you actually characterize them on imaging, whether they are involved nodes or it is just inflammatory or some kind of granulomatous lymph nodes?
See, mostly the paper which I showed, it highlighted that very rarely, if there are pulmonary hilar lymph node, they will be involved by metastasis. The other thing is, for imaging, if we see bilateral pulmonary lymph nodes with some necrosis, or we see both hilar lymph nodes with subcarinal lymph nodes, then it generally point towards some granulomatous or some latent tuberculosis which has been reactivated. The thing is, it is very difficult to sample that area, and that is definitely a gray area. What to do when we see pulmonary hilar lymph nodes post NACT-RT. So we are also in a very big problem after when we see this kind of situation. But generally in our hospital, what is the protocol? If we are seeing pulmonary hilar lymph nodes, that is, and if the primary disease is responding, so we will just go for upfront treatment. We will not send for palliative chemotherapy.
Okay, means
right. So Dr. Manish, one question from you. So once we are talking about the pulmonary hilar lymph node, so how easy it is for you when doing a esophagectomy, you harness that node?
Yes, we can take out the pulmonary hilar lymph nodes. See, most of the time we see lymph nodes which we can on table also we can recognize them that they are not looking malignant. Sometimes they are, means by the consistency and by the color of the lymph nodes, but yes, true, we cannot grossly we should not say, and most of the times we take out these group of lymph nodes if they are enlarged.
Okay.
So right pulmonary but not but left is difficult because we mostly do esophagectomies in prone position.
So, but it will be, but according to the AJCC, it is taken as a non-regional lymph node.
Non-regional only, yes.
Right. And next question is, you have already taken it up, image characteristics of the metastatic
Dr.
lymph
Shefali,
node. Yes, please.
This is Dr. Prashant
yes,
here.
please. Yes, please.
Coming to the, just a word of the point regarding the hilar lymph node involvement in esophageal cancer. So these are something really challenging, and most of these, even on PET, majority of these are likely or granulomatous, and not come across so frequent positive nodes from esophageal cancers to hilar lymph nodes.
Right.
So I think you cannot just call off a patient just because you have a PET positive hilar lymph node, because that is not the draining zone for esophageal cancer. And it is not the draining zone. I agree that they can be, cancers can spread anywhere, but then just based on that, unless and until the uptake is so avid, and then without proof, it's better not to call off patients because they lose the opportunity of cure just based on
definitely.
And that's a message which needs to go loud and clear to the residents across. You just see a hilar lymph nodes. I think, 30 of us get scanned, get a PET scan. I'm sure that we'll all have hilar lymph nodes positive one.
So so if I summarize it for the sake of students, so if the whole chain along with the hilar lymph node is involved, better try to prove it. If isolated hilar is there, please don't leave the patient as a metastatic or a palliative intent. Just go and treat him as a radical intent, unless until it is so gross on PET that they label it clearly as a metastatic disease, right?
Index of suspicion based on morphology as well as metabolic. Just purely go by metabolic abnormalities alone and call off a patient. This is very important. Yeah, this is very important when it comes.
Generally, SCF nodes and retroperitoneal nodes are very approachable to sampling. So technically, they should be taken up for sampling to prove what it is, then go ahead with the further treatment.
Correct. So we'll go to the last question. So Nupur has asked, like we discussed, lower cervical nodes are regional. But as I think you mentioned in your talk that supraclavicular should be considered as metastatic. So Dr. Bharat and Dr. Prashant, Dr. Dixit sir and Dr. Manish. So you all are there. So we need a clarity on that. Okay, so should supraclav be taken as a regional node or a metastatic node, or does it depend upon the site of involvement of esophagus? Because Japanese classification and other few classification also mention that supraclavicular may be a regional drainage area for even the lower esophagus nodes. So what is your take on that? So you, Dr. Bharat, you can take the question, followed by Dr. Dixit sir, Dr. Prashant and Dr. Manish.
I will tell you what is followed in our hospital. So according to AJCC, it is non-regional lymph node, but for lower thoracic and G-Junction tumors, so these are taken as non-regional definitely. So, but upper thoracic and middle thoracic, they say that they try to operate depending upon the laterality of, if it is medial, they can do the surgery. If it is too lateral above the clavicle, they will not try to operate.
Right. So, Dr. Dixit sir, any more comment?
Yeah, Dr. Shifali, actually, more than the anatomy, we also look at the histology. So suppose if it is adenocarcinoma with supraclavicular node involvement, definitely it is not a regional node. We consider it as a systemic spread of the disease. But if it is a squamous cell carcinoma, still coming to the extensive celiac and parietic nodes, we call it as a metastatic disease. I think there is not a very thin gray line, very difficult to differentiate. But most of these patients, since they are going for a systemic treatment, either cross trial or magic trial protocol, I think reassessment following the neoadjuvant treatment and tailoring the treatment based on the response to the treatment is very important. I think we
agreed, sir. Agreed.
Personalize cancer care rather than the cancer treatment.
Right, sir. Very well taken point. Dr. Prashant, you want to add something?
No, nothing. I completely agree with Dr. Jagannath, sir. And it's a very, very important point. It's not just the mere anatomical location. The pathology to be given. I would still treat the patient if it's a squamous cell carcinoma, lower third with a supraclav with an 3-field lymphadenectomy. lymph node dissection for it, and it has shown survival benefit in a small series, no randomized controlled trials, but then still in Japanese series have shown excellent survival outcomes. If it's an adenocarcinoma, sir rightly mentioned, I mean, it has to be treated as a non-regional metastatic.
Yeah, wow.
Right. So, Dr. Manish, should we go ahead with the next talk?
Yes,
or you want
yes,
to
we
add
should
something?
go ahead. Yes,
Right.
we should go ahead with
So,
Dr. Prashant.
wonderful discussion so far. So now I would like to invite Dr. Prashant Penumadu, who is a surgical oncologist from JIPMER. So he would be taking a lecture on pre-operative workup and nutritional aspects, basically, for esophageal and G-junction cancer. So I would request every other person to please be on mute so that the clarity for lecture is there. Thank you.
So, yeah, thank you very much, Dr. Shefali, Dr. Sanjeev, Dr. Manish, Shubham, and team Max team for giving me this opportunity. But I have to confess that the entire topic looks like has been covered in the previous talk, because most of it is radiology as a part of pre-operative workup. And
इसका एक size extra मंगा थोड़ा चिपक.
Please, everybody, please go on mute. Somebody on Galaxy A71, please go on mute so that we have the lecture clarity. Thank you. Please proceed, Dr. Prashant.
Yeah. So it might be a repetition of majority what Dr. Bharat had covered, but I haven't put so many images thinking. So I'll try to make it brief and probably adjust. I'll try what best I can not to bore you all in the next 10 minutes.
तो पहने ही ये पहन के आ जाते रोज रोज.
Yeah, I'm sorry. So this is what we'll try and cover up. I always divide into diagnostic workup, staging, fitness evaluation, and then among the diagnostic workup, barium swallow was considered the gold standard prior to any of other radiological imaging to diagnose malignancies, but no longer now. But for the sake of residents, I think it's important to know that such an investigation exists, and these are some of the old images that way back in 2000s, where barium swallow was routinely being done for almost each and every patient. Even now, for motility disorders, mind you, barium swallow is being done, and certain lesions can be picked up, but I don't see a role in 2021 of barium swallow. Without endoscopy, remains the investigation of choice, and in fact, the first investigation of choice for a patient who presents to us with dysphagia. And here I've shown you different patterns of lesions that can occur, varying from superficial to ulcerative to stricturous to circumferential lesions. And it is important that the number of biopsies be taken are adequate enough, and the diagnostic accuracy entirely depends on the number of biopsies you take. 3 biopsies, you have a diagnostic accuracy of around 93%. 4 biopsies or 5 biopsies, you have about 95%. And 7 biopsies, which is minimum what is suggested, has an accuracy close to 98%. And it is important, and especially when you're dealing with Barrett's esophagitis or any other pre-malignant lesions, probably you will need to do 1 centimeter multi-quadrant multiple biopsies or a 2 centimeter multi-quadrant biopsies. What are the important points to note for you as a surgeon when you are planning what kind of treatment, and even for a radiation oncologist? Important to know, I would be keen to know the distance from incisor, distance from G-junction. It's not just important, it is not just enough for me if I do an upper GI scopy and my resident calls me and tells me, sir, it is in the middle esophagus. A circumferential growth in the middle third of the esophagus is absolutely no use information. The surgical planning entirely depends upon this, and it is preferable that the surgeon himself or herself does the scans himself, so that you'll have an idea whether you would want to, what would be your extent of resection and also your reconstruction. Biopsy from the most, also look for coexistent dysplasia and identify the location of the tumor. This is with regards to endoscopy. And staging evaluation, I always teach my residents local staging, and metastatic workup, and then you also work up for fitness. The same way as you present any of your cases. Local has been extensively covered, so endoscopic ultrasound. And I would like to stress here the importance of bronchoscopy and laryngoscopy. CECT, chest and upper abdomen probably remains the initial investigation of choice for a patient. But if you have a diagnostic, which if you have a biopsy proven, my investigation of choice would be directly a PET contrast enhanced CECT, rather than doing two investigations, CT and a PET differently. It would reduce the cost and it would give you the same information as what it does. So endoscopic ultrasound is for what does it, how does this help us? It actually helps us in early lesions. It's very unfortunate that in our subcontinent, we do not see these kind of lesions at all. I'm yet to see a T1a esophageal lesion. I would be happy to see one, but it's very unusual that we see early lesions, and endoscopic ultrasound is the modality of choice to differentiate between T1a or anything less than T1a or even T1b. And compared to CT scan, the accuracy is 71 to 92% for T stage, and end stage is more or less similar, but maybe when you club it with an FNAC, it definitely increases. So this is some data on meta-analysis. So can you use US in advanced tumors? Yes, probably in two uses. One is in the preoperative to know its local infiltration to surrounding structures, and sometimes infiltration to surrounding structures post neoadjuvant chemoradiotherapy, though challenging because of post-RT changes, it can still predict resectability in about 66%, which is not only, but it is a good amount in squamous cell carcinomas. And as I said, EUS, the sensitivity, the accuracy increases to 90% when you increase it. When you add an FNAC to the endo ultrasound. Now coming on to the bronchoscopy, yes, I would always do a bronchoscopy for lesions confined to the upper and the middle third. That is till the left bronchus cut off. Anything below that, you wouldn't do a bronchoscopy. But also it's important to do a laryngoscopy, because to look for second primary, where the incidence can be as high as 5% described in literature, but we don't see them that commonly what literature describes as. And vocal cord status is also important, because AP window nodes are certain group of nodes which are more likely to be involved in squamous cell carcinomas of the mid third, upper third, or the lower third, and huge nodes causing left recurrent laryngeal nerve palsy is one of the relative contraindications to treat with a surgical modality at some point of time. What do you look for in bronchoscopy? Predominantly, you look for the tracheal wall mobility in bronchoscopy. And for the sake of residents, how do you do it? Put in your bronchoscope, get to the trachea, right bronchus, left bronchus, make the patient cough when the scope is inside. You would see the membranous portion of the trachea and the bronchus moving. If in case it does not, probably they're good. Here, if you want to confirm it further, two modalities. If your scope is not negotiable across the esophagus, EBUS is a good option to tell you infiltration. PET-CT, as I've said, is amazing. I will not get into it, but for distant, this on the right-hand side, as you can see here, is for nodal, and on the left-hand side is for distant metastasis, has been extensively covered. And PET-CT is the investigation of choice for initial treatment. For response assessment, as rightly mentioned by Dr. Bharat, a CECT would be adequate enough to take a call, unless and until there is a progression of disease. When there is a clinical progression of disease, I would definitely redo a PET to make sure that I am not offering patient and morbid surgery without any added survival advantage. And there is also data coming up on the PET response, linking it with outcomes. Yes, it's important, but it's still under clinical trials and not to be used as standard of care. And for GI-Junction adenocarcinomas, I would add on staging laparoscopy, mandatory for all these group of patients, because peritoneal disease, though missed on PET as well as on CT scan, can be as high as 30%, which can be picked up by invasive staging laparoscopy. Now coming on to workup for fitness for surgery. The first and the foremost thing that I see in the outpatient clinic, whether the patient would be able to tolerate. Mind you, it is not surgery alone. Esophageal cancers are multi-modality treatment. Let us talk about advanced because we rarely see T1, T2. We are not going to talk about T1, T2 or early lesions were confined to T1. Let's talk T2 and above. It's almost always a multi-modality treatment. So you have to look at the patient's fitness in terms of tolerance to neoadjuvant chemotherapy, neoadjuvant chemoradiotherapy, and surgery all put together. If a patient is fit for surgery and is not fit to undergo neoadjuvant chemotherapy or some kind of because mind you, esophagus, there is no role of adjuvant therapy, whatever it is. If you have to give adjuvant RT or adjuvant chemotherapy, there's absolutely no benefit in esophageal cancers. So these are the three things which I immediately look at, and how the patient walks into your clinic. And the quickest test which we do regularly at JIPMER for all patients of thoracic malignancies, including be it a lung or an esophagus, is a quick 6 minutes walk test. No desaturation, no dyspnea on Bog scale. If a patient is able to walk about 380 meters, this is from our own data, 380 meters, probably the chances of having pulmonary complications post either neoadjuvant chemoradiotherapy and surgery is less when compared to those patients who are unable to walk. And 2D echo is an important depending upon the comorbidities. And if the patient has multiple comorbidities, one test which can be really helpful is to do an arterial blood gas, which is quick bedside, and which will really help you for any thoracic surgery for that matter, be it a lung surgery or an esophageal surgery. So this is how I work up my patient for a preoperative this thing. And also, mind you, it is also important to look at the imaging, because the amount of lung, how the quality of the lungs. You have an extensive patient who has extensive COPD with bronchiectasis changes. These are patients who are not good for radiation, neoadjuvant chemoradiation, and maybe you should look at alternative options. And maybe even your surgical modality would completely change from a transthoracic to a transhiatal, if it's lower third, or maybe even definitive or palliative, depending on the. And for any thoracic malignancy, be it lung or esophagus, the primary and the most important thing is patient fitness. If the first thing patient wants, whether the patient is fit to undergo or not. I may request to mute others because I think it's a little bit interrupts and the flow is lost, if you don't mind.
Yeah, I have muted that who was there. No worries. Please go ahead.
Yeah, okay, great. So that's about the working and fitness. And this is how you take up the preoperative investigations in these group of patients. And the other most important thing in an esophageal cancer, especially, and even in gastric for that matter, is preoperative nutritional optimization. The most common reason for malnutrition in this group of patients is inadequate intake, fatigue, cancer cachexia. This leads to muscle and weight loss, and they will not be able to tolerate multimodality oncology treatment. Reason? Preoperative nutritional optimization, if not done, can have severe effects on toxicity to neoadjuvant treatment. And it is one of the most important independent factor that predicts survival. So these are some of the cancer cachexia, sarcopenia, and frailty used in synonymously are some of the principal components of preoperative nutritional optimization. So ESPN has come out with wonderful guidelines on preoperative nutritional optimization for all cancers put together. But then I will share with you few evidences and also few personal experiences. So it has been shown that a severe involuntary weight loss, that is anything more than 10% before cancer surgery, is associated with a worse survival, but surprisingly no increase in complications or length of hospital stay, and lower BMI patients are at higher risk of post-operative complications. And even the other side, the other extreme, is the higher BMI patients, or also more than 35, are also risk of pulmonary complications. But however, if you compare VATS versus open, definitely VATS has a lower incidence irrespective of the BMI when compared to open surgeries. And it is also proven that dietitian delivered intensive nutritional support for all patients is definitely associated with a significantly lower morbidity and a higher completion rates to neoadjuvant chemotherapy, and with fewer hospital stays and overall. So in our center, we have a dedicated nutritional, a dietitian who delivers the required calorie intake, the protein intake, and also it's also important to keep the patient hydrated well. How are you going to do it in a patient with dysphagia? Either through a nasogastric tube or a feeding jejunostomy. Never stent a patient if you're planning for a definitive treatment at any point of time. It is challenging. It is challenging. I wouldn't say impossible, but it is challenging to operate a patient post neoadjuvant chemoradiotherapy post stenting. We have done a couple of cases, but trust me, it is especially in the mid-third, the amount of additions that post stenting has, the morbidity is going to be severe. But there are equal number of studies which says that stenting is safe and can be done. But personally, I wouldn't prefer to stent a patient because we can achieve the same amount of nutritional rehabilitation using feeding jejunostomy or a nasogastric tube or a nasojejunal tube. So sarcopenia, the prevalence varies widely between 16 to 75%, much higher among our group of patients. And unfortunately, down south, we do see a lot of patients who actually walk into our clinic are not fit for any kind of treatment, especially in esophageal cancers. And we know that sarcopenia is a most important indicator for post-operative complications as well as pulmonary complications, and also early mortality in terms of. So these are some of the high risk features that you need to watch out for these group of patients, because this disease is associated with extreme cachexia and catabolism. Any severe weight loss of more than 10 to 15% in 6 months, low body mass index, subjective global assessment grade C, and any serum albumin less than 3 in the absence of hepatic or renal failure. These are patients that you need to really put an extra effort to rehabilitate them. And what would be your nutritional goal is to prevent the catabolic state. And it's important that you avoid the muscle mass, modulate inflammation and immune response, and attenuate the hypermetabolic response, and also at the same time consider providing micro as well as macronutrients to optimize healing. It generally starts before at diagnosis as early as possible, and to optimize for a mildly malnourished patient, because the patient, mind you, even neoadjuvant chemoradiotherapy is more toxic than surgery. For high risk patients, it has to start even much more before you may have to wait for even 3 to 4 weeks, reassess the patient, and then take a call regarding any further definitive treatment. So we look at managing at 25 to 30 kilocalories per kg per day with a 1 to 1.5. Sometimes you can go up to a protein of 2, and with the daily usage, the recommended daily allowance as per all the multivitamin and the multi-nutrients. Essential amino acids should be supplemented. Enteral nutrition at all points of time is very, very important, and it should be sufficient. But if you feel it is not, do not hesitate to start parenteral nutrition in a patient who is being planned for any of the definitive treatment. Immunonutrition, ESPEN guidelines recommend the use of immunonutrition in perioperative or at least in the postoperative period in malnourished patients in undergoing all major cancer surgery. Mind you, this is not for esophagus, but however, randomized controlled trials have shown no difference in postoperative outcomes following supplementation of immunonutrition. And for residents, I think ESPEN guidelines are one of the beautiful guidelines when it comes to nutritional assessment, and the recent guidelines have been published, and I would suggest that all of you all should read these ESPEN guidelines when it comes to for nutritional assessment. And it is also that fast track or ERAS protocol is quite important and effective in these group of patients, those who are undergoing surgery for esophageal cancer. The simple things like not to keep them fasting for long and adding a carbohydrate overloading 2 hours prior to surgery is an important thing, which the ESPEN has come out, has shown definite improvement in postoperative ileus as well as reducing the postoperative nausea and vomiting. To conclude, PET-CT is the choice of local and distant staging investigation. US choice for local and regional early stages. I wish we could get more of them. Nutritional care should be an integral part of multimodal oncology treatment, without which I don't think these patients can be treated or can be cured. And start early nutritional support before the patient develop profound metabolic abnormalities. And most important, which I did not cover in detail, but I wanted to conclude, encourage patients to stop drinking alcohol and stop smoking 4 to 6 weeks prior to surgery, because it not only has an impact on surgical postoperative morbidity, but even the radiation tolerance is very, very poor in patients who continue to smoke. With this, I conclude my talk, and I would be happy to take any questions.
Yeah, thank you so much, Dr. Prashant, for again a wonderful talk and discussion. So, Dr. Manish and any other who would like to ask questions in view of the pre-operative workup and all. Yeah, Dr. Manish, please.
Yes. So thank you, Dr. Prashant. It was a very beautiful lecture, and you have covered very nicely, few very basic points. So I just want to ask one question for the benefits of students, which is very routinely asked in exam actually. So what are the basic bedside pulmonary function tests which we can do when we are planning these patients for esophagectomy?
Yeah, sorry, I didn't cover that in detail because I thought it was for a post-MS student, so that's why. But yeah, I will take that question. The most important bedside pulmonary function test generally done is an FEV1 and FVC. Both are equally important in these group of patients. And mind you, it is also important to look at the post-bronchodilator, the response to post-bronchodilator, and anything more than generally 60% patient is fit for an esophageal surgery. So more importantly, unlike the lung surgery where PFT is more important, here for me, I would stress more on the exercise testing modalities. The dynamic modalities like stair climbing test or a 6 minutes walk test, which would give me much more information.
Yes.
Mind you, PFT is something which even a very literate and a person who can understand how to do it also cannot perform a PFT.
Yes.
Well. I mean, I have to confess, I myself couldn't do a PFT well. My values were so low, but I don't think, I'm sure that I can climb at least 10 flights of stairs without getting tired. So it is not that easy to convince, and we have started doing the 6 minutes walk test routinely for all our patients because our PFT values were horrible in majority of these patients. None of our patients could ever understand correctly.
Yes, rightly said. So one, yes. 6-minute WAT test is a very good test actually, which tells us about the cardiopulmonary reserve. One more test is like we can ask the patient in OPD itself to just check their breath holding time. That is another test which can assess
Exactly.
their cardiopulmonary reserve. So these are some basic tests which we can do bedside to assess their cardiopulmonary reserve for surgery. And do you recommend like a PFT in all the cases of esophagectomy?
Yes, to be on safer side, I do PFT in all patients in esophageal surgery. Yes, sometimes I go to the extent of very rarely doing a DLCO in a patient who has extensively, as I said in radiology, if you have a patient with extensively COPD lungs, barrel chest, sometimes even DLCO prior to neoadjuvant chemoradiotherapy, at times, yes, I would do it. I would do PFT in all patients undergoing mind you, pre-starting of any treatment for that matter. It is not pre-surgery alone.
Right.
Okay, so one more question, Dr. Prashant. Is there a ideal weight criteria, because these patients are nutritionally deprived, these patients are undernourished or lose weight because of not ability to eat? So bare minimum, do you follow weight criteria or a general health? I mean, just to make a decision whether, suppose somebody is 25, 28 kgs, he has lost 10 kgs. So you build upon nutrition or so. So how do you take that criteria as?
Yeah, so generally weight is going by weight alone is not a criteria, because for a person who is about 5 feet may differ, and you cannot put a cutoff on the weight. I've seen I've operated on a 28 kg old girl and have gone on day 5 without absolutely no complications, but at the same time on a 50-year-old with, so there's no cutoff for weight. But
right.
When I start to do nutritional assessment, all esophageal cancers, there is no doubt in that. I will not wait for, that the patient will lose. He is bound to lose weight. Whatever said and done, is bound to lose weight. But as I have mentioned, the 4 important criteria, when you assess by pre-operative nutritional assessment, the 4 most important criteria, when with a low albumin, more than 10 to 15% weight loss and falling into grade C category, these are the patients where I would aggressively treat these group of patients. With a dietitian, I would involve a dietitian and make sure that they receive about 25 to 30 kilocalories per kg per day, proteins up to 1.5 to 2. Recommended is up to 1.5, but then 1.5 to 2 times. And the patients where I would aggressively look up at this thing.
Right.
I wouldn't take a cutoff of weight.
Right.
More than the percentage fall which the patients come to us.
Right. So, is there any more questions? So I can't see any question in chat box. So if there are no more questions, so I would like to thank all of the faculty members for their valuable time and contribution. And we'll be posting the information about the next talk, which will be on surgical management of esophageal and G-junction cancers. So thank you all for having all of us here. Thank you so much. Thank you. Yeah.
Thank you.
Thank you.
Thank you.